Okay, good morning. Welcome, and thank you for participating. Those of you who've heard me before, I want to say that this is going to be a very different kind of webinar. And what's different about it is I've got some fresh thinking. You know, it's interesting, just as an introduction. I started my work with John Money at Johns Hopkins, and I worked in the sexual problems and gender clinic there, and worked a lot with sex offenders and sex addiction. And after I left there, I went to Masters in Johnson and worked in sex therapy for 10 or 15 years. And it's an interesting kind of background to have, because as time went on, I decided I wanted to change my focus to working with trauma and dissociative disorders. And so I spent many years working in a dissociative disorders clinic. And then over time, I wanted to learn more about eating disorder. And so eating disorders have a lot of things about them that are very different and very similar to sexual addiction. But I realized when I worked with eating disorders that no matter how much work I had done with women, I really didn't understand women and their relationship with their bodies as a man. And so, I basically lived with anorexia for many, many years, trying to understand that. And at this final evolution of where I am now, I keep getting incredibly new insights. And having done this for more than 50 years, it's always surprising to me that I haven't plateaued and that I'm learning new things every day from my clients. So these webinars are my attempt to sort of put together what it is that I'm realizing that I didn't know before. And when I realized that so many of the books that I've read are missing these really key components. So that's what I want to say today. So that will be my introduction. And where I started really was, I had this interesting experience at Johns Hopkins, where I went to school, of getting to meet John Bowlby, who came in for a semester, and Mary Ainsworth was there and had her courses at the university. And so I was brought up with attachment theory. And so I developed a developmental perspective on psychopathology. And that was the time when Schwartz and all that wonderful work in developmental psychopathology began to evolve. And it was a whole different lens of looking at psychopathology, which was, that people present with eating disorder, with sexual addiction, with alcohol and drugs. And what's so interesting is that the symptom is where they present, but that's not really what the problem is. A symptom is a manifestation of the problem. So behind all symptoms is the problem. And so, the question with each client is to ask yourself, what's the problem we're working on here? And that's what I'm going to be talking about today. The symptom is developed as a survival strategy. Oftentimes it was necessary back then to survive, but now it's a dinosaur that's hurting the person. The symptom is logical and rational. 2 and 2 always equal 4. And if you have a person who's really interested in being tied up and whipped and urinated on in order to get sexually aroused, there's a damn good reason for it. And so I tend to think more ideologically than phenomenologically. And the symptom remission is dependent on understanding the logical development. In other words, I believe that you have to have a developmental perspective. I think in order to do treatment, you have to know the contributing factors, and that's very different than traditional psychiatry. Okay, so that's sort of the way I think. Now let's get down to work. I read this interesting article by Janot and Shore lately. It was called Intergenerational Enactment of the Trauma, the Role of Unconscious Self Systems. And I'll give you a reference for it. But this article really shook me up. And I'll tell you why. It says, more understanding is needed into the psychological and physiological process underlying intergenerational transmission of trauma. Intergenerational transmission means that what you pick up from your family of origin and what they picked up from their family of origin. A child who herself did not suffer sexual abuse, for example, but is nonetheless subjected to her mother's overly promiscuous attitudes or conversely strict, rigid approach to dating, will inhabit many shades of her mother's fears, emotional reactions to men, and defensive adaptations. Now, when I read that to you, it sounds sort of obvious. We have intergenerational transmission of shame. But when I think about that, what I realize is that we're missing the boat. If you talk about treating trauma, the first thing you think about is PTSD trauma. And when you think of PTSD trauma, you think of exposure therapy or cognitive reprocessing therapies. And yes, that's very effective for PTSD. We go to the next step and say, well, what about complex trauma? Complex trauma is being in an environment of inescapable stress where you're involved every day with terrible, overwhelming, neglectful things in your life. How do you treat that? And we've become more sophisticated in that in the last 5 years. But I promise you that the real problem with the most of our clients is not just PTSD and not just complex trauma, but a third type of trauma, which we have not well named, which is intergenerational trauma. And that most of the bad things that a person is doing is more related to that. So for example, if a woman comes in and says, I keep picking destructive men in relationships, when I'm having sex with somebody, I find myself, terrified and not aroused. We want to do sex therapy, which, approaches the symptom, but that's necessary, but not sufficient. And the reason is because there's underlying trauma. And so sometimes people would go to, well, maybe they were sexually abused, or maybe they don't remember it, or maybe there was complex trauma. But what we don't go to sufficiently is the realization that actually, in most cases, the sexual symptoms are related to the intergenerational transmission of shame. And how do you do exposure therapy with someone who didn't actually experience the trauma? The mother or the grandmother experienced the trauma. And that's the question I want to beg a little bit today. And they say, emotional intensity among survivors and their children are expressed in hyper and hypo arousal affective states, such as fear, mistrust, and helplessness. Now, I'm saying to you that sexual inhibitions, sexual addictions, sex dysfunctions, they're all related to what this is saying. Hyper and hypo arousal affective states, such as fear, mistrust, and helplessness, that bleeds into the erotic system. Consequently, the child's trauma-suffused unconscious map, unique to each individual, is made up of many shades of emotions and meanings, echoing a parent's emotional and cognitive self states. I love when people use words and say exactly what needs to be said. And that's why I give you these quotes. I love that echoing because, John Money, my teacher, used to call that love maps. And a love map is an echoing of the unique map inside somebody's brain of what turns them on. And it's so interesting to wonder why it is that a person picks the same destructive partner. My father was an alcoholic. I've married 3 alcoholics. Why is that? That's the intergenerational transmission of trauma. And I want to talk to you about what causes it and how to treat it. And indeed, a wide-ranging studies have demonstrated that children of trauma survivors generally suffer high levels of cortisol. Now, what is this? What we know is that the definition of post-traumatic stress that Rachel Yehuda offers us is a dysregulation of the downloading of the ACTH cortisol system. It's the criteria for PTSD. So what she's saying here is that there are now data showing that some children are born with PTSD and they've inherited from their parents not doing the work about their own PTSD. Now, the number of cases that I have seen where, the mother was raped, molested, and done no work on that at all, and is a phobic, she gets into a relationship with a man who has his own set of issues. In one case, the man is primarily homosexual and starts exposing his genitals in public. And then they have 3 kids and they homeschool them. And each of them has their own set of sexual problems, each of them related to how they process what happened in the family of origin. And if you have that person come in and you say, oh, what causes your asexuality? And they try to give you words for it. And they might say, well, this happened to my child. But are they ever going to be able to articulate what it was like living in a family system with a mother who did not work through her own rape, married to a man who's out exposing himself, and a family-based shame where they isolate and homeschool? And then if you get down to the etiology, how the hell do you treat that? And that's what we're going to be talking about today. And the first picture slide, you don't all have a copy of, but we're going to insert them. This is the presentation that I just talked about. The client comes in, and I call this dead eyes. And in the dead eyes, you see it with the dead eyes, they come in and, okay, she has sexual inhibition. She doesn't really turn herself on. Maybe I should get a divorce. Maybe I don't love him. How do I know if I love him? I think I'm better off alone. Long ago, I realized that most sexual problems were disorders of intimacy. It's kind of interesting to think historically. You know, I did sex therapy at Masters and Johnson, 10-session sex therapy for a long period of time. And in this sex therapy, you know, you could deal with surface issues, but how do you really get down to, in a brief therapy, working with sexual inhibition, you know, that has the roots that we're describing in some ways? And how do you help her deal with her mother's rape when it happened to her mother and didn't happen to her? All right, emotional intensity among survivors and their children is expressed in hypo and hyper-arousal affective states. Okay, so the child's trauma develops an unconscious map and made up of emotions and meanings echoing the parents. And so she is actually working through her mom's sexual inhibitions subconsciously. Okay, so, all right, so now let's add to this what we see with an adolescent. You know, we have COVID. They're locked in their room. They are given their computer or iPad. They're having hyperarousal because they're pubertal. And they're having social anxiety because they're not interacting with people. They already have low self-esteem because of social anxiety and trauma or complex trauma or intergenerational trauma. And so they lock themselves in the room. And what do? They look at pornography. Now, that's an epidemic which we're beginning to see. They become absorbed with the pornography at a time when their brain is differentiating at an incredibly rapid rate. And most individuals begin looking at porn at age 11, and in many ways it shuts them off. You know, being in their room, looking at their device, they become dissociated, they become one with that. And now add to it the absorption that is involved with sexual arousal anyway. So, you know, you're fantasizing. Now, what are you fantasizing? Well, you know, I tend to open these websites up, you know, to be able to understand something about my clients. And, you know, I guess I must say, I'm rather horrified by what I'm seeing on there, which is, you know, there are 10 million people looking at these sites that are rather, terrible things are being depicted. And so what we're doing is we're frying into our children's brains images that are indelible and imprinted in there in some way. And now 10 years later, I see them when they get into a committed relationship, and they're having one hell of a hard time to be able to make love with their partner. So I don't want to be too negative because there is good pornography, I guess. in the sense of anything that allows people to see passionate, caring people care for each other and be sexual and get a sex education. So there might be positive factors and negative factors. It's just that we're at a crazy state in its development. So what happens is they get unrealistic expectations, like you would be even when looking at the Playmate of the Month. You get an overdependence on the visual rather than touch. And it's oftentimes dehumanizing, turning person and other into object. The accelerating factor is that, people are getting an education and they're dealing with their loneliness and intimacy difficulties, but in destructive ways. So what we're seeing is a whole new generation where it's endemic on a public health level of being fried into their brains pornographic images, and it does change the whole nature of everything we do. And I think that the more we understand dissociation, the more we can begin to help such individuals. And so that's what I want to talk about. Overuse of internet pornography is similar to a dissociative condition. There can be a huge amount of distortions. I mean, my client comes in, he says, I spend 3 hours looking at pornography. And I say, okay, how do you do that? And he says, what I do is I edge. I go to the point of almost reaching orgasm, and then I go back, I go edge again, I go back. I turn one thing arousing on, and then I turn something even more arousing on, and then I turn something more arousing on. And what they're doing is by edging is they're increasing, they're almost developing tolerance right in front of you because they need more and more in order to get the same arousal, and they're frying that into their brain. And they're going to a dissociative trance, which is, dissociation is absorption, acute narrowing, complete loss of awareness of immediate surroundings. I mean, Jesus, what can be more dissociative trance than that? Unconscious movements on the mouse or the computer, searching over and over for intense erotic stimulation, and linking of sexual addiction and dissociation to the addict self. So to a person who's had trauma, literally there's a fragmentation of the personality and ego states that kind of get into some deviant stuff, and they can be a Dr. Jekyll and a Mr. Hyde. So what we do is we used to have, sex above the belt being beautiful and wonderful and romantic, sex below the belt being dirty and disgusting and filthy, and save that for the one you love. And that distinction that was 30 years ago now can be set into ego states, and there can be an ego state that is the bad you, and the ego state is the good you. Sometimes in the old days we used to call that the Madonna whore thing. But now these Madonna whore things become discrete states in the brain that become more and more distinguished because they're fed with pornographic imagery. And so the parts of self become even more distinguished. And so what that looks like is, you'll say to a person, what happens when you masturbate? What happens when you're having sex with a partner? And what we're getting is intrusion of ego states. So, it's like, I'll give an example. You go to make love with your husband, and a child part jumps out and says, ew, this is dirty, disgusting. But if you go out with some guy at work where you're doing something illicit, another part comes out and wants to seduce him. So we have a part that's sort of seductress, we have a part that's little girl, and these parts are distinctive. And it's obviously very confusing to the client. And so you're beginning to understand the dissociative nature and how these subset systems get built into the brain. And, if you set an fMRI up, you could actually see different parts of the brain being activated when the child self is out versus the seductive part of self. And this can be pretty confusing if you're getting married, because when you're dating somebody, you might find yourself very highly aroused. And then on the day you get married, you might lose all your sexual interest. And it's profoundly confusing to the couple. But I would say I probably have seen that presentation more than 100 times. So I just want to, as I leave this section, remind you of the 10 sexual problems using porn. And So I really ask people to have abstinence from porn. And I tend to ask them to find certain sites that oftentimes are created by women or have much more passion and are not done with great illicitness, but are kind of beautiful and lovely, and want to begin to change the imagery. But personally, more than not, I'd rather them have a complete absence from pornography while they're learning to make love with their partner. Mother Nature tends to be fairly robust, and we can repair this, but whatever. Now you can say, yeah, porn doesn't require internet. You're absolutely right. But what we're seeing now is, the fact that the internet is so quickly is easy and available at 3 o'clock in the morning that people are going to that. But I must say, people are going to Craigslist and other sites and they're having hookups, and we need to talk about that. And obviously you can have other forms of pornography. All right, I want to now move to my favorite topic, which is I want to add to it that if we're talking about dissociation, we're almost always talking about disorganized attachment. And the reason we are, if you haven't seen this, is if you remember Schroff at Minnesota and his colleague Agawa, they followed longitudinally children who had disorganized attachment for 30 years. And eventually they looked at the ones who were age 19. And what they found was that children who had a history of disorganized attachment in adulthood presented with dissociative disorder. And that the disorganized attachment was more predictive of dissociation than even trauma was. Now that was mind-blowing because what we always thought was trauma created the dissociation. Now we realize it's more the disorganized attachment creates the dissociation. So if I'm saying that we have clients who are highly susceptible to dissociation, now beginning to have separate ego states, they are probably having disorganized attachment. And so for the last 20 years, I've been trying to come up with modalities to treat disorganized attachment in adulthood. And as some of you know from my past webinars, the place I went for that is to Mary Main. She developed the adult attachment interview, and I got myself trained in the adult attachment interview so that I could learn how to assess and diagnose disorganized attachment and then come up with interventions to be able to repair it. Okay. Now, you all know that when dissociation prevails, there's a fragmentation of the self system. Most of my clients who are addicts come in, they say, I don't know who I am. I feel like I'm an imposter. I am codependent. I do what other people want me to do. And the idea then is that they're highly built with otherization. What happens then is there's a disorder of the self system. They don't know who they are. And there's a disorder of the emotional regulation system because they don't learn how to deal with these strong, intense emotions. And so what they do is they turn to alcohol or drugs as a way of modulating their affective states. Well, in a very similar way, a person can turn to eating disorder. And if you don't eat, you're going to be fairly numb or you're going to get fairly high. And that becomes a way of regulating. So Jean Briere used to talk about how these addictions are ways that people eventually discover to regulate a dysregulated emotional system. And if they're born with PTSD and they're born with a dysregulated cortisol system, then they're going to be highly susceptible to addiction. Now, bring sexual arousal in. Now the sex addict then turns to the whatever it is that is the order of their sexual map. They plug into that in a dissociative way as a way of regulating. And so they masturbate 2 or 3 times a day and condition themselves. If I feel sad, I masturbate. If I feel lonely, I masturbate. If I feel hungry, I masturbate. Any emotional state can be modulated by the output of the behavior. And so the reason that's important is as soon as a person practices abstinence, all the stuff that they have not dealt with, they still don't know how to deal with. So they don't know how to deal with loneliness. They don't know how to deal with anger. They don't know how to deal with sadness the way the rest of us do, because over the years at 4, 5, 6, 7, 8, 9, 10, they've never learned how to deal with these states without using their sexual arousal. So abstinence is only the first stage of treatment. And it's the same thing with all addictions. Once a person's abstinent and under control, that's when the therapy actually begins. So in our program, which is a partial hospitalization program, it's like, go somewhere else, get sober. And then once you get sober, let's begin therapy. And that's a very different way of thinking. And so a partial hospitalization program for us was the treatment of choice, because now that you're sober from eating disorders, sexual addiction, alcohol, drugs, now we can really get what's underneath it. And actually there's more similarities than there are differences in how you're able to deal with that. Although there's a unique knowledge base required for sex addiction that's different than alcoholism, which is different than for eating disorder. And I've had all three experiences. So it's allowed me to be able to get perspectives I never could have got any other way. Next. I'm saying to you that dissociation sets the stage for the loss of true self. So we get back into Winnicott, Kohut, and the object relations theorists, because our clients are coming in with a false self. And what we're trying to do is seed the development of the real self. Now, if you want to read anything on seeding the development of the real self, where do you go? Masterson, of course. So what I want to say here is sometimes we keep reinventing what we already know. And if you haven't read Masterson, if you haven't read Kohut, if you haven't read basic object relations theory, that's where it's at. And that's at the key of all of this stuff. And that when we make something complex, let's go to the simple. The most simple thing we can say is that the true self becomes corroded with a badness. And honest to God, over a 50-year experience as a clinician, every single client comes in with shame, shame, shame. And they feel like they're defective. And nothing you say in cognitive behavioral therapy, no matter how many times you ask them to objectify, to test out, to look at irrational belief systems and do that old cognitive behavior good stuff, it's necessary, but it's rarely sufficient, because shame is in the affective system, not in the cognitive system. So what we're doing is we're talking to the cerebral cortex and helping the false self become more false. Oh yes, I know that I am a good person, but why do I feel like I'm a bad person? And if we don't get to the deeper levels of what's in the affective system, it's going to influence them unconsciously, and the unconscious is still going to affect them. So now you've been able to change their belief systems about themselves, but it doesn't seem to go down to the root in varieties of ways. So there's always the question, how does one change these shame-based systems? And the first thing to remember is it's not about what happened to them, it's about what they inherited intergenerationally from their family of origin. And that's really an important concept to be able to get. But stick with me, because this is exciting stuff. All right. Now, this shame stuff, it's like when I worked with anorexics, if I listened to the voices in their head, it was overwhelming. It was, I just had one client just write down, what they were getting in a 15-minute period. We're talking about self-hate of enormous proportions and anxiety up the gazoo, because everything here is generated out of anxiety, and whatever it is that's going on in group, this is the stuff that's going on in their head. And, trying to be able to get them to realize that in a cognitive behavioral way and work with it is certainly an essential step. We do it, it's necessary. But what I'm saying to you is it's never sufficient. Now, think of this with regards to sexuality. You get nude with another person, you're excessively vulnerable, and suddenly you begin to get flooded with thoughts of perfectionism, of self-hate. I'm dirty, I'm a slut, sex is scary, whatever. You have a lot of negative attitudes that were transmitted intergenerationally about sex that flood your mind and get in the way. But even more important is the affect that gets flooded in. This is disgusting. Now imagine a husband and wife coming in and the husband saying, I want oral sex. I'd like her to go down on me. And the wife says, it's just disgusting. I hate the smells. I think it's disgusting. When I think about it, I want to puke. Well, a sex therapist would begin to work behaviorally with that. And what you found in sex therapy is you've got to change their attitude before you can change their behavior. As long as you think something is disgusting, you're never going to eventually be able to do it with comfort. So exposure is useful, but changing people's attitudes is necessary. But now let's say that there are longer roots to this, and it's tied to disgust that the mother transmitted around the body, around sexuality, around weight, and it's tied to so many other issues. It's funny. It's like when I was younger, I didn't know so much, and it was easy to treat this stuff. But now that I'm older and I know so much, I realize how complex this stuff is and how much I was missing early on in my career. And so, that's why a lot of people get better, but then they relapse because there are layers that have to be done. And what you're doing may be necessary, but may not be sufficient. And if we followed up our clients for a long period of time, we'd probably find that the vast majority of them relapse. I remember when I first began to read the work in marital therapy, and I was really an excellent marital therapist when I was 30. I did Richard Stewart stuff, and I did really good marital therapy. And then, along came the research saying that, the vast majority, 80% of our clients were relapsing and divorcing. And what we were doing wasn't effective, and we had to reinvent marital therapy. Well, I guess I'm sort of saying the same thing. As I read the books on sex therapy, the traditional books that are out there, all 10 of them or something, that what I see is what's in there is good stuff and it's necessary, but we're missing the core and aspect of this. I don't know any book that really gets down to what we're talking about today, which is the dissociative nature, the splitting of the self system, how you root the development of the self system, and understanding that all sexual problems are problems of intimacy and attachment. And therefore, you must treat the intimacy and the attachment disorder that underlines the sexual disorder if you really want longevity with regards to change of the symptoms. Now you say, well, Mark, that's really weird coming from somebody out of Masters and Johnson, because Masters and Johnson were saying that you can treat this in 10 sessions with 80% effectiveness. Like, what the hell's wrong with you? And the answer to that is, yeah, you probably can treat in traditional sex therapy through brief therapy. But what I'm saying to you is that what Marshall Lanahan said was, our job is not just to get rid of the symptoms, it's to help create a life worth living. And in a similar kind of way, that I said to Bessel van der Kolk, okay, we can treat PTSD effectively, I buy that, but don't get an illusion that that's effective treatment, because treating the PTSD is necessary, but it's not sufficient. It's necessary to treat the PTSD, but now we have to help the person create a life worth living. And what we've not done is delineated the steps to be able to do that. And now I'm saying this with regards to sexuality. We can get rid of a sex addiction. We can get rid of erection problems, but underneath those symptoms, someone is waving a red flag saying, I am having disorganized attachment and I have major intimacy problems, and I keep going through relationship after relationship in a destructive way. I don't understand why. You're taking away the symptom, but you're not treating the problem underneath the symptom. And that's really what I want us to understand far better. So this sounds also esoteric. Let's get down to a case. I have a guy who comes in and he likes to have prostitutes beat him. And he's married, has kids, and he feels like that he's going to end up getting divorced and losing his job when they find out that he actually is hiring prostitutes. And so I access the part of him that's out doing the dirty deeds. And that part comes out and it is very dissociative. And I tape the session, and here's what the client says. And I want to read it to you because I learned everything from my clients. So I want you to ask yourself, what do you learn from this client? The part of self that goes out with prostitutes and has the prostitute beat him says, sex is dirty. It feels good, but I want no part of it. It only makes life miserable. Your penis will fall off if you have sex too often. All it's good for is causing trouble. You can't feel sex, you can only hurt it. After all, my mom uses it to fuck my dad and Johnny. That's all men are good for, so mom can fuck them. Well, fuck them all. I don't want to have sex. It's evil and good for nothing. It only makes me feel bad. It's why mom is never home. She's out fucking and hurting men. I wonder if she has other kids. I hate sex. I'd cut my dick off. Mom would like me better. She hates boys. She just wants their dicks. She keeps them on her trophy shelf. Johnny and dad are fools. They think she wants their stupid useless dicks. Well, everyone knows that they're ugly and should be cut off. I'd cut yours off if mom asked me to. After all, what's it good for? It just gets you in trouble. That's why mom liked my sister Julie more. She doesn't have a dick. Girls always call the shots. You can't put your stupid dick inside of them unless they let you, and they only let you if you beg them and plead. And you're good at that because you can only please mom by giving her your dick. She makes you such a fool. Sex is her toy to enslave men. She uses it to control Johnny and my dad, and they hate her. But because of sex, they're tied to her. What weaklings they are. If they would stop wanting to have sex, they could not control them. They're like robots. She pushes their buttons with sex. They're idiots and they deserve what they get. She doesn't do anything and they follow her sex smell because they have no brains. I like beating off with Brian. Sperm goes right where it belongs, into the toilet. I always want Brian to beat me off. He does it really good. See, sex is dirty, but we need it to survive. Look with dissociative disorders. What you look at is what's called an entrance ritual and an exit ritual. The entrance ritual is sex is dirty, it feels good, but I want no part of it. There's your inhibited sexual desire. And the exit ritual is sex is dirty, but we need it to survive. Isn't that interesting? Now, thank goodness I taped this because I couldn't have written all that down. And in it is the door into the treatment of my client. And if I didn't know this, the question is, how could I treat it? And so this is now what I do with all of my clients. I identify the sexually compulsive part of self or the sexually inhibited part of self. And I access that ego state, usually using internal family systems therapy, ego states therapy, Gestalt therapy, or some sort of affective way. I've not been trained in somatic reprocessing, which I hope to correct because that probably is the treatment of choice. But in all of these, I'm able to get this kind of data. And when I get these kind of data, it teaches me what I need to do with the client in order to get better. You're probably saying, what the hell do you do? And I will tell you. This is like those news shows on TV where you watch the episode and then you have to wait a week for the next episode to figure out what happened. Okay. So before we get to that, I got to give you the full picture. So we're talking about the development of the self and the split off self systems. But the other side of this is the affective system, because everyone knows that trauma is encoded within the affective system. And it's the affective system that's really going to be so critical. And so there is that Jean Briere beautiful example I talked about earlier, which is what he said in 1992 was these activities provide one of the following: temporary distraction, interruption of dissociative dysphoric states, anesthesia of pain, restoration of control, distressed and compatible sensory input, temporary filling of emptiness, self-soothing, and specific relief of guilt or self-hatred. Okay, now shit, does that say it perfectly? I mean, what is a person doing? They come in, they're making love with their partner, but man, they're using it in a whole different way. When I was treating eating disorders, the first thing I learned was never talk about food in the way that I use it. because for an eating disorder client, their relationship with food is in no way similar to your relationship with food if you don't have an eating disorder. They are using their bodies as objects, the food as objects, and their internal relationship, what their mind is doing with food, you have no frame of reference of. So if you say something that applies to you, you would be wrong if you tried to apply it to them. And so I needed to understand the internal ways that the person was thinking about food to treat the eating disorder. Now, the same sort of thing about sexual addiction. Eating disorder is not about food. Sex addiction is not about sex. Oh shit, what does that mean? It means that it's like a red herring that's pulling you off. It's about affect and dysregulated affect. And the person is binding their affect with some addictive behavior. And so they're using it as a way of getting back under control. They're using it as a way of numbing themselves. They're using it as a way of self-soothing. And when you then give them abstinence, they don't know how to control themselves. They don't know how to self-soothe themselves. They don't know what to do with that intense emotional self-hatred they have. And so that's where the therapy begins. And those things are not about sex. They're about anxiety. They're about emotions. They're about affect. And many of our clients, particularly those who have avoidant attachment, have absolutely no window into their affective system. They don't know how to feel. They don't know how to experience feelings. They don't know how to express feelings. They don't know how to use feelings. They are alexithymic. Okay. Now, maybe I'm preaching to the choir here because all people who deal with addictions know this, but it hasn't been sufficiently applied to our understanding of these different hypo and hypersexual states. So self-care, 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 self-care. Once you become abstinence, the primary focus of therapy is teaching a person how to take care of themselves, how to nurture themselves, how to be able to calm themselves down, how to be able to recognize their emotions and be able to deal with their emotions. And on the self side, to recognize their values, their esteem, and their cohesion. When you don't have a self, you don't really know what you're living for. You don't know why you're living, and you've never really thought about it much. So if you say, what's your life about? What are your goals in life? What's important to you in life? And what are your explicit values of how you live your life? If you don't have a self, you really don't know that. So I began to study acceptance and commitment therapy, Hayes's work, because it seems so valuable in helping a person begin to differentiate some clarity about who they are. And it always starts with their values and their values about self and others. And my general belief is that you can't like yourself unless you know what your values are explicitly and you live a life committed to living within your values. And so if it is not in your values to steal and you steal, you're going to hate yourself. And so it's important to know what your values are and where they come from. And if your values come from what you think other people think of you, you're in trouble. So what one's values have to come from is internal, not external. And to go through that moral development stuff that Kohlberg used to talk about and get to the point where you can have an adult value system. Now, when I would treat sex offenders, what I learned was the most important intervention was beginning to develop empathy. Empathy where you no longer wanted to hurt another human being. Now, how do you help a person develop empathy? Answer: you begin to help them look at what blocked their natural unfolding of empathy, which is trauma. And as you would begin to do the trauma work, empathy would begin to emerge. And so the way I was trained, you don't have to teach people to have a natural function. You just have to remove what the roadblocks were. For a number of years, I worked in a prison, and then I worked for probation and parole with rapists. And I did that because I couldn't have even imagined how a person could rape. I had no frame of reference how a person could get to be that disturbed. And what I found was that these individuals that I was working with had severe trauma in the first year or two of life and neglect. And as I began to work with the trauma and neglect, wow, that what began to emerge in terms of affect and emotion and empathy and compassion was beyond my comprehension. I don't think anybody in that system would believe what I saw happen. And so it's removing the blocks that cover over that then allows that to happen. How can you love if you don't have empathy and compassion? And empathy and compassion needs to be looked at. Now, I've said from Jean Briere that these are ways of getting under control. When everything seems out of control, i.e. trauma, then you need something to get back in control. If you're in an environment of neglect and you can't trust the people who take care of you and you don't feel safe and you're scared all the time, you're going to reach for something. And so with the eating disorder clinic, food was the answer. So binge eaters, taught me an enormous amount where, you gain 200 pounds and it's the only way you can feel safe and in control. And so as I learned to treat binge eating disorder, I understand another aspect of how you deal with sex addiction, because it's your way of being in control when you're terrified alone. So if you're a little boy and you have no friends and people are mean to you and bullies beat you up and you can't talk about it with anybody and you don't know your feelings and you're numb and you have avoidant attachment, reaching out for a sex addiction would obviously be the treatment of choice. Now, if we stop the sexual addiction, i.e. sobriety, oh my God, look at all those years of things that didn't happen developmentally that you don't know how to do. It'd be like throwing somebody out of a parachute out of a plane without a parachute. And so, I often think that practicing abstinence in the way 12-step programs do it is a little bit dangerous, because you want to get a person in control of their addiction, they're going to be cold turkey and they're going to be flooded with all that terror and fear. And they need somebody by their side to be able to teach them what they don't know. And so, the programs have ways to be able to do that by talking to others, but these are actually real skill deficits and habits that they haven't learned. And so I always encourage people in 12-step program to be in individual psychotherapy. All right, so what the food and sex addiction have in common is alleviating sexual tension for self-soothing and feelings of emptiness. And they're more similar than they are different. Okay, now let's get down to it. There's a book by Chefetz on dissociation that, is a game changer. It's such an interesting book. And what he says, I'm going to give you a couple of his quotes because they're breathtaking. He says that from a dissociative process perspective, thinking about how the normative but separate domains of sensuality and sexuality create a need to discover the subjective nature of a person's sexuality and the extent to real sensuality might exist during sexual activity. Sexuality without sensuality needs investigation. Okay. Sexuality without sensuality needs investigation. Underline that. The absence of a clear and coherent sense of being present in one's body and experiencing the sensations associated with sexual activity, including sensual ones, is an indicator of the dissociative isolation of somatic experience from its awareness. The human need to hold and be held is missing in action when this isolation of somatic experience occurs. Wow. The woman says, I'd rather be knitting than having sex. And while I'm doing it with him, I'm a million miles away, but he never notices. Okay, now, that's sex therapy, right? Now, sexuality without sensuality needs investigation. We call that fucking. And it's oriented towards orgasm. And so many people, when they're having sex, aren't there. Won't believe this, but a million years ago, Dr. Masters and I at Masters and Johnson were very interested in sexual fantasy patterns. And what we began to do is ask people who were not clinical, more about their fantasy patterns. And he wrote about this in his book called Homosexuality and Perspective. And in it, what we found was that most people, when they were making love, were not thinking about their partner. They were away in their fantasies, and the stuff that was going on in their head was very surprising, which is, and I'm not talking about a clinical sample, a normative sample of people, they were thinking about nothing. They were thinking about emptiness. They were thinking about noises, zoom, zoom. They were thinking about people without faces. And there was lots of imagery of violence that would come in, and it would be required to turn them on. And so what we concluded is that when most people are making love, they're not present in their bodies, and their minds are being distracted in order to turn them on. Now, if that was true at an endemic level in the population, we had a public health problem. And the public health problem was not just that people were not knowing how to make love with their partner mechanically, but in their heads, they were so filled with shame related to sexuality that their mind were not allowing them to be erotic and sensual, and their dissociation was of such a degree that they weren't even with their partner. They were a million miles away, or if their partner was a million miles away, they didn't even notice. So, so much of what Masters and Johnson did was mindfulness. And so all this new revolution in mindfulness, as you apply it to sexuality, is recognize that most people have body dysmorphia. Dr. Masters used to say, as a gynecologist, I never met a woman who is satisfied with her breasts. They're either too big or they're too small. And the same thing can be true about people on diets. Everyone's on a diet. They're too fat, they're too thin, they're too this or too that. Our inability to be in our bodies and to be able to relive our bodies. Now, there are so much of this is realized now. I mean, the Tantra approach to sex, people who are doing body work, the somatic therapists. I mean, I know I'm not saying anything you don't already know, but this needs so much more attention with regards to sexuality, because I'm telling you that if you read the traditional sex therapy books, there's not a lot of this stuff in there. And this is where it's at. And part of the reason it's not in there is because people have not had enough experience in working with dissociative disorders. And we're all kind of recognizing that. And a lot of these new modalities, like EMDR or IFS or ego states therapy, or the variety of other therapies, voice dialogue therapy, so on, they're all waking us up to this new door. The other thing that he says in this book, which I love, is that, well, we'll get there in a minute. I'll hold that sentence. Okay, so our approach to sex therapy then, succinctly, is entitlement. And so what Masters and Johnson taught me is that you say to the client, it is understandable given what happened to you, what you've done to yourself as a result of what was done to you, and the destructive influences on your choice of partner and the relationships you created, you do not feel sexual. And what was missing from that was it's understandable that growing up in your family and the family's family that your family grew up in, and the shame that you imbibed from that, and then what happened to you as a result of that, and what you've done to yourself. So there's like 6 layers of stuff that we have to get through. You're entitled not to feel sexual. Now, you could say, well, how does that help? Because it immediately takes the pressure off. Our partner doesn't feel loved if we're not turned on by them, but it has nothing to do with whether you love or turned on by your partner, really. It has to do, it's an inside job, not an outside job. And so it's an inside job, not an outside job, means that the work has to do with your relationship with you, not your relationship with them, your relationship with you. So you say, well, do you do individual therapy or do you do couples therapy? And the answer is yes, I do individual therapy and I do couples therapy. And I do another kind of therapy, which is I like seeing the individual with a partner in the room. because then the partner says, holy shit, I thought it was about me. I see it's really about his mother's mother. And it takes all the pressure off that in the relationship. And the person then stops putting the demands on the partner to perform when they understand the depth of where these things come from. And so if I have my therapy of choice is to do individual therapy with a couple. All right, so sexual desire is largely anxiety driven. In the earlier phases, like romantic love, there's a part of self that comes out. I call it the seductive part of self, where you want to conquer your other. And you conquer others because each person, it's like you are what you eat. Each person that has sex with you makes you feel like you're a worthwhile person. And if you're empty inside, you need to put marks on the wall. So adolescence is filled with that because it's a time when the self system is beginning to differentiate, and neurons that fire together wire together, and says Dan Siegel. And our goal of psychotherapy is integration. So what we're doing in adolescence is we're integrating a real self. And as the self is getting integrated, we may need many others to know that we're okay. So we fuck in order to be able to feel good about ourselves. But for some people, it's like insatiable. You go on and on and on. And I used to find that in the gay community. People would have what are called tricks. And you'd go to a gay bathhouse and you would fuck somebody, and then you'd get high, and then you would drop down. It would like be doing crack. And you get down so low that you'd have to have another trick in order to get back high again, and then you would fall. And so bathhouses were a lot like doing crack. They were incredibly addictive, up, down, up, down. And at the end, the person would be suicidal and really need to do something about that because they felt so bad about themselves. And so what we're doing then in the less extreme cases is, as we have affairs, what we're doing is we're taking the emptiness of self and trying to fill it by, oh, that person wants me. And if you don't love yourself, you need external verification of lovability. And so, that's the basis of codependency, is helping a person have an I before they have a we and be able to deal with their own dependency needs. Next slide. All right, so the apparent compulsion to repeat these tragic scripts is desperate, unconscious effort to get coherence. And, what we're really trying to do with repetition compulsion is fix something. Jean Briere used to talk about there's a repeater system in the brain. And if you watched, let's say your father beat up your mom, and you'd say, I love my mother, I love my father, but I hate what my father does to my mother, so on. It resulted in different ego states inside the brain, because the only way you could make sense of that, which made no sense, is to have disparate dissociative systems in the brain. So now that you've got this brain with different dissociative systems, and so what happens is later you marry your third alcoholic husband. You promise yourself you're not going to marry an alcoholic husband, but then you marry your third alcoholic husband. Why is that? Because an ego state that is split off from you, i.e. unconscious, is trying to figure out what happened and why it happened. And so Jean Stoller used to say that our life is dedicated to reliving the trauma in disguised form. Whew, that says it a lot. And Chefetz says it in this way: the repetition compulsion is a tension between dissociative processes activated by fear and associative processes of unresolvable confusion. It's a dissociative puzzle. So the common features of sexual and dissociative disorder is a vulnerability to dissociative episodes of depersonalization, dead eyes, secretness as a way of life. I don't know why I lie. I just lie all the time when I don't need to. Relationships have a quality of falseness. I love you. Wow. What do those words mean? And is it coming from your head or from your heart? And what is love? And why is it we're so interested in that word when it means so little? The rigidity of cognitions and distortive thinking. Standards of perfection are adopted in hopes of gaining acceptance and approval. I have to have the perfect body. I have to really be a great lover. It's a perversion because you feel like you're you're always living like in fear that someone's going to think you're a premature ejaculator and tell everyone at 17 years of age, even though you're age 40. You feel powerless in relationships. You're afraid that someone's going to abandon you because all the kids in high school did, or all the girls in high school did. And at an unconscious level, you're reliving those fears in disguised form. All right, so I'll tell you an interesting story. There was a guy named Loud Humphreys. I don't know if you remember him. Around 1965 to 68, he did this interesting study, which is he looked at men in the tea room trade, and he would pass himself off as a voyeur, and he'd watch people put their penis through glory holes and then have the penis sucked on the other end. And the reason he was so interesting is because the question is, how could anybody get an erection when you don't even see anybody on the other end? And, you know, if you think about that, how horrifying it is, you can imagine somebody with all the violence doing something damaging to your penis. So he would ask them, what are you thinking about when you're having sex? And what he found was that they weren't thinking about anything. And as I talked to Dr. Masters about that, what we discovered was that there are a group of people which we call bypassers. And bypassers are people who don't seem to need a partner to be desirable. Now, why am I talking about a 1964 study? Because as I look at what's happening on the internet, my clients are telling me that at 3 o'clock in the morning, they're depressed and lonely. They call up and they have someone on Craigslist visit them at 3 o'clock in the morning. And I'm thinking to myself, who in the hell would have a stranger come visit them at 3 o'clock in the morning in their own apartment? And I'm reminded of Loud Humphreys and a bypasser. So they come in my office and I say, what if the person is not pretty? What if they haven't taken a shower? What if they're this? What if they're that? And the person says, it doesn't really matter. And that interests me. Not only does it interest me because it's so odd, but it interests me because it's so common. Hookups are of epidemic proportions, and they make no damn sense because it's so dangerous. And so I think we have to go back and we have to revisit this concept of bypassing. Now, I think that a lot of people are having sex with their husbands and wives and they're bypassing. That is, that they somehow in their mind be able to, at some point, be able to go away in their mind and to be able to not be present. And why is it that a person would bypass? Well, because there's so much shame and so much trauma associated with sexuality that natural function comes through, but they can't allow themselves to imagine. So an ego state steps in and numbs them out. And so their sex actually with a partner becomes addictive. They're masturbating in someone's vagina using pornography of the other person, really. Okay. Now, all this you're thinking to yourself seems articulate and right, but what do we do about it? And so now I want to go to the last phase of what I want to say. All that I've said so far is about disorganized attachment. Disorganized attachment is a dissociative phenomenon. It means that there's a splitting of the self system. It means that there are ego states, and it means that there's an intimacy disorder. Okay? Now, how do you treat dissociative, disorganized attachment? Answer. In the adult attachment interview, what we do is the way we score a person as disorganized attachment is one, they have loyalty to their perpetrators, meaning that they come in delusional and they think my life was fine, my parents were great, everything was good. Now, loyalty to the family is a neutralizer of recognizing how much intergenerational transmission there is of shame. It's antithetical. So the first step is to begin to do family of origin work where the person does what they call at Menninger plain old therapy. I love that concept of plain old therapy. If you read the Menninger people, they have what is called mindfulness generated therapy, mentalizing therapy, reflective function therapy. And if you haven't read Fonagy, I really recommend, or if you get a chance to listen to him, he's mind-blowing. But Fonagy, who's at Maudsley and sometimes at Menninger, he gets it. And he began a whole revolution in what is called metacognitive therapy. And metacognitive therapy really needs some discussion. So bear with me because these terms sound so esoteric, but if I explain it to you, you'll get it. In metacognitive therapy, a person is able to watch themselves think. And so it's looking at self through an airplane. Watch themselves think. That's metacognitive therapy. And a lot of what Marshall Linehan was teaching us was metacognitive therapy. And that's why it was really effective with that problem. But in metacognitive therapy, what you're doing is you're breaking the loyalty to the family and develop what we call fresh thinking. Fresh thinking is beginning to re-examine what you've always thought and determine whether it is indeed true. So plain old psychotherapy means we're not going to look at our life through rose-colored glasses anymore, but we're going to go back. When I did my own therapy, I talked to my brother, I talked to my two sisters, and they're older than me, and I would ask, do you remember this? Do you remember that? And I tried to get validation and verification of some of the things that I remembered and felt growing up. And as I reconstructed the pieces of the puzzle, it was almost like a puzzle and it was missing pieces in some ways. And I would do reconstructive work around that puzzle. And it allowed me to be able to know things and see things that I had never known or seen before. Example of that. I asked my sister, do you remember a policeman bringing me home when I was really young? She said, when you were so young, you could barely walk. At 10 o'clock at night, the doorbell rang and a policeman had you at the door. And he found you like 20 miles away from home. And it was funny because none of us knew you were missing and we couldn't imagine how you got there. Now, I love that story because it helped me make sense of about 100 other things that didn't make sense to me about, I was the fourth of four children and, I was, they were sick and tired of having kids. And a lot of things followed from that. But as I began to do that, the rose-colored glasses disappeared. And it wasn't that I learned to hate my parents. It was that I learned to understand what happened to me. And as that happened, a lot of things happened in my therapy and my personality began to change. Now, if I use that as an example, what I'm saying to you is that metacognitive is being able to look at things through a different lens. And the lens of where was he 20 miles away from home when he was 5 or 6 years old, no one knew, and a policeman brought him home, is a lens that I want to look at things through. And it's metacognitive and valuable in understanding other aspects of what happened in my life. Now, that's metacognitive kind of thing. Now, when you're dealing with disorganized attachment, what you're trying to do is allow a person to be able to integrate. Now, there are parts of self that then get manifested. And so you know that a part is there when your feelings are out of proportion to a situation. So let's say somebody dies, but you can't grieve it properly. Let's say that a boyfriend or a girlfriend breaks up with you and you can't, and you go into a crazy state that's not like you. Let's say you have rage attacks. All those are windows into disorganized attachment. They're separate ego states that present themselves. And each of them is a gift to the therapy. Because if you follow the rage, if you follow the unresolved grief, if you follow the sexual addiction, if you follow the inhibited sexual desire, each of these states will lead you back to the events developmentally that came in and allowed them to unfold in some ways. And bringing those states into consciousness is what psychotherapy is about. Unconscious coming into consciousness, plain old psychotherapy. And so metacognitive therapy is essential for beginning to work with these dissociative states. So I went ahead and I started researching metacognitive therapy. And apparently in social psychology, they've done a ton of work under metacognitive states, and they've begun to delineate specific metacognitive states and dissect it out in varieties of ways. And now what I've done is I've taken some of that work, some of it was done in Italy, and metacognitives, there's a metacognitive scale, which you can look up under Google, which was done in Italy. It's just incredibly precious. And as you begin to look at these metacognitive states, we can be able to, an example would be one of the things in a metacognitive state is called decentering. And decentering is where you see everything through your eyes, but you can't look at it from the perspective of the other. Now, why is that important? Because what is trauma? Trauma is an absorptive state. And what is empathy? Empathy is the ability to look at what happened to another person as separate from what happened to yourself. If you're a sex addict, you are not able to decenter, and you're not able to feel empathy. And what you're doing to another person, hurting another person, you can't feel. The skill of decentering is a metacognitive skill that a person learns how to do. When do you learn to do that? Probably at the age of 12 and 13. Where were you at age 12, 13? You were in your room looking at computers. So it's what you didn't learn at that point. So because we could do top-down interventions and our brain is incredibly robust, so much of this can be done in good psychotherapy. But what we have to delineate is what has to be done in order to be able to do it. So it's not that I'm against cognitive behavioral therapies. I want much more targeted cognitive behavioral therapies, which are oriented towards the developmental skills and the affective recognition of what didn't happen at age 4, 5, 6, 7, 8, 9. And I'm saying that's necessary for a person to develop true empathy and compassion and decentering from yourself from another person. Well, that's an example of a metacognitive skill. So when the Menninger people caught on to was in metacognitive therapy, I read the book, I wasn't getting it until I really understood what I'm saying today, which is that the real treatment for disorganized attachment has to do with understanding metacognitive states and doing much more metacognitive-based therapies. And that's the work that I'm beginning to do now. And I'm encouraging you to read up on it, because the ultimate thing that it reminds you of is that we are treating disorganized attachment. We are treating dissociative disorder. And when I did a study at my previous treatment center, first 100 clients I gave the adult attachment interview to. And of those 100 clients, over 90% had disorganized attachment. And I said, I am not going to treat the eating disorder. I'm going to treat the disorganized attachment, because those are the ones who are going to get better from eating disorder. And when I did that, that's what turned out to be true. Now you say, well, what else is in this treating of disorganized attachment? Not only is the metacognitive work, but the first thing that Mary Main said is that you have to have a cohesive, coherent, collaborative narrative. A cohesive, collaborative, coherent narrative. Now, what the hell does that mean? Well, you do a timeline with a client and look at what they remember. Well, I forget the first 10 years of my life. Well, that's dissociative. And so in reconstructive therapy, what we want to begin to do is put the 10 years back into their narrative, a coherent, cohesive, collaborative narrative. Now, what is coherence? Nobody knows what the hell that means. Coherence means that the way you think and feel and act makes perfect sense. And that if you go back in a developmental perspective, we will identify that 2 and 2 always equal 4. what gets put in the computer always comes out of the computer. Now, if you go back to that thing that I read to you, where the person says sex is dirty as an entrance ritual, and it's why was he having prostitutes beat him? Because sex is necessary. We need it to survive, but if you need sex, then you're bad. So the best way not to need sex is to bring a prostitute in and pay them. Well, that's a perfectly reasonable solution to that dilemma. But now you know what the dilemma is, you can help the person resolve it in some way. That's why I say, even though it seems crazy, it's perfectly rational. So coherence means that everything a person does makes sense, including being urinated on or having no sexual arousal. And 2, there is a developmental origin to that. And 3, you must learn what that developmental origin is in order to treat the person effectively. And so coherence is beginning to do this deep kind of work of beginning to integrate one's past, present, and future as what Dan Siegel says is necessary for psychotherapy. And then part of a coherent collaborative narrative is something which is called reflexivity. Reflexivity is the ability to reflect on your own experiences, remember how they felt, and to feel them. And so a person who's been sexually abused does not want to remember how they felt. They don't even want to remember it. And a lot of the psychotherapies say, oh, don't do memory work. Don't allow the person to go back and remember it. It's just a re-victimizing experience. And I mean, the problem with that is that in many ways, it's playing into the dissociation. Dissociation is don't think about, don't feel, bypass. And what trauma work is allowing a person to have one foot in the past and one foot in the present, and to be able to work on memory without being re-victimized. I'm remembering what Bessel van der Kolk said last week to me. He said, we forget that trauma is about terror. Trauma is about terror. And a lot of people are using the word trauma wrongly as, oh, this bad thing happened to me. When you have PTSD, you experience terror. And exposure therapy is the treatment for terror. Because if it's unconscious, it's like, oh, and if you can't remember it, every time you go to have sex with somebody, your unconscious is going to be triggered and you're going to get that terror while you're making love. And how can you be intimate with somebody you're terrified of? That's the ultimate puzzle of disorganized attachment. How can you be intimate with somebody you're terrified of? Your own mother, your own father, you needed them, but they terrorized you. And terror is different than fear. It's a much greater proportion. And so being able to have reflexivity means that you remember how it felt and why it felt that way. And that you can then have internal states of feelings, intentions, needs, and so on. And so what we want to do is we want to bring the emotional system back online so that they can not only observe what they're thinking, but what they're feeling and how numb they are, because so much of this stuff is unconscious. No, when you're nude with another person, you are incredibly vulnerable. If the light's turned on, you're even more vulnerable. And it is a catalyst to all the unconscious, shameful, unfinished business of the past. And what we want to be able to do is to be able to wake up emotions and affective systems. So in our program, I mean, what we do is every group, 6 hours a day. How do you feel? What are you going on in your body? Let's get back in your body. What are you going to do with those feelings in your body? Where do you think that anger went to? Where do you think the anger is going to go? And what are we going to do with that anger? Because it's all suppressed and stuffed in there, that rage, because when you are feeling terror, you are going to feel rage. And if you don't do something to release that rage, then the person is stuffed with it in varieties of ways. So most of my career, I have tried to define what is an intimacy disorder. An intimacy disorder is disorganized attachment. The same person that you fall in love with, you are terrified of. And you have an approach avoidance And sometimes you're preoccupied, love me, love me, love me. And then when they finally come, it's like, run like hell, I'm scared to death. And what kind of partner are you going to pick? And what are you going to reenact with that partner? Relationships are alive, and you recreate all that unfinished family of origin business. When a couple divorces, it's such a rich opportunity to begin to look at what happened in their family of origin that they've repeated in some way and reenacted and recreated, because usually the divorce has little to do with their partner. It has to do with what happened in their family of origin and what they recreated with their partner. And they're not a victim. Actually, they're the one who's perpetrated themselves. You've turned their partner into their perpetrator because they're a masochist and they're recreating a lot of the pain that they once had in certain ways. Okay, so I think we're probably at a good point where we could begin to take some questions.
Mark, you've got a couple of questions in the questions area, and we also have some questions that came in the chat. And let me summarize those for you. They're around disorganized attachment and particularly linked to the mother. And can intergenerational trauma come down from an abusive father, as well as attachment disturbances with the mother?
Yeah, thank you. Those are good questions. The number one cause of dissociation is having a dissociated parent. Dissociated parents create dissociated children. So that's a really important thing to remember. And that disorganized attachment can come from a parent who's 1 minute kissing you, 1 minute slapping you across the face. And that is really confusing in certain ways. Now, why do I pick on the mother? Good question. I think it becomes even more confusing when you have a family where lots of strange things are happening, and particularly with a high degree of divorce, people going to live with mother, people going to live with father. I think they're getting it from both directions. So probably a lot of the things that I've said is about using the mother is erroneous. It's always both. So as you mentioned, the intergenerational aspects for the clients received from their mothers. What about dissociation connected with the father who was sexually abused as a child? Is your experiences, have you found differences? Good question. I think it's complicated, and I think it's whether you're a boy or whether you're a girl. And I think it's highly individualized because, at certain ages, kids seem to have mother hunger, whereas at certain ages, they seem to have father hunger. And for example, when they get to be, there's this wonderful book called Father Hunger. And a lot of people find that father hunger was behind a lot of anorexia. And so that's a good example of how a different manifestation can be related to disorganized attachment with one person versus another. But truth be told, I don't know the answer. I need to think about that much more and study it. If you've thought about it, I appreciate what you could contribute. Second one, I work with betrayed partners, betrayable trauma, and sex addicts. They present with disorganized attachment because they're not. Can a person develop disorganized attachment later with a new trauma? I think that's a controversial point. I don't think so. I think disorganized attachment has to be laid down in the first 5 to 7 years of life, and it's a critical period. And the reason I say that is because these patterns that we're defining in the strange situation seem to be so long, have such longevity, but oftentimes we recreate those patterns later in life. So I suspect that it'd be hard to, if somebody had secure attachment early in life, I think that they're unlikely to develop disorganized attachment later, even with severe trauma.
There is one here that says, can dissociation be multifactorial?
Yeah, I mean, part of it is the problem with the definition of dissociation. Bessel says there's primary, secondary, and tertiary dissociation. And the kind of dissociation today we're talking about is a fragmentation of the self system, which is more tertiary dissociation. But depersonalization is another form of dissociation. And a lot of us have dead eyes. That's depersonalization. And then dissociation can come from, when you're experiencing a PTSD trauma, leaving your body. And a lot of people leave their bodies while they're having sex. And that's primary dissociation. So those are different aspects of dissociation. All three of them are oftentimes true with our clients. And the way you treat each of them is radically different.
How about this one? What assessment do you use to measure disorganized attachment?
Well, there's lots of them now, and they correlate with one another in consistent ways. Everyone thinks the gold standard is the adult attachment interview. And then there are pencil and paper ways to measure it. In my groups, I use the pencil and paper ways so that people have a frame of reference of what they are, but rarely do people not know. They can look at themselves pretty clearly and put themselves in a category. But I like the adult attachment interview. I've been trained to give it. I've been trained to score it. And I do that basically with all my clients. One of the questions in the adult attachment interview is, tell me 3 adjectives to describe your relationship with your mother growing up. And then the person will say, well, we're very close. And I'll say, tell me a story about being very close. And the person will say, well, one time when I was sick, she called and she arranged for my sister to pick me up and take me home from school. And that would be an example of potentially disorganized attachment, because the story doesn't match very close. On the other hand, if the person said, I grew up thinking my mother and I were very close, but as the years came on, I looked at that and I realized that my mother was busy at work all the time. And the only time we really got together was, on weekends, and we could have really friend-like conversations. But I think I needed a mother. I didn't need a friend. That would be secure attachment, because the person is metacognitive and is able to look at it in varieties of ways. So that's an example of how you begin to use the adult attachment interview to really understand your client. And after I was trained in it, I felt like I could do much better psychotherapy.
Mark, how can you help a young person develop a healthy sexuality?
Well, first of all, kids learn from what they see, not from what you tell them. So sex education is a bit of a misnomer. Giving people information about sex is not necessarily sex education. What one has to do is give information about sex, but they're getting it all over the place. But they need, John Fowles used to say, we teach sex to children like sending a ship out to sea without a rudder. And what he meant was the ship would go out and just run around in circles. We're exposed to sexuality all over the place. And, 7 to 10-year-olds are looking at the visuals on their computer, but we're not providing the guidance of how to guide the ship. And that guidance has to come from what kids see, not what they hear. And so, if you're laughing every time you're talking about sex, you're sending shame messages. And if every time it's brought up, you turn the TV off, you're sending messages, and so on. And so, in effect, if the parents have done their own work and are not transmitting shame around sexuality and present it in a healthy way, that's sort of the best sex education. Dr. Masters used to say, there's nobody in America who's grown up with healthy attitudes about sexuality. And I don't know if that's true or not, but I think we're all affected by that in some ways. So what is sex education? It begins in the family and is not only taught about sex, but it's about love. When I was younger, I used to teach a course called Love Education at Johns Hopkins. In the first class I taught, I was 21 years old, had 700 people in the class. And there was no book on it. I just had to figure out what to teach about love education by myself. Now there's lots and lots of material on this. But what we need is to separate sex education from love education in preparation for relationships. And preparation for relationships need to begin at a very young age, because how we relate to self, how we relate to others, and how we relate to the world around us is doing trauma work. How we relate to self, how we relate to others, and how we relate to the world around us. And so I do a lot of work in values clarification. And you have to know your values, and then you have to have value clarification exercises to begin to ask yourself how you think, and then to respect each individual's values and values clarification.
Mark, we've got one here. Can you link cheating to trauma?
Cheating to trauma, yeah. Yeah, I think of cheating as an intimacy disorder. I think of cheating as a reenactment, as a repetition, and it always has its roots in intergenerational trauma. And I'll give you an example. One of the clients presented, and he was a sex addict, and he had an affair with his wife's best friend. His wife got a separation, and he tried to commit suicide. So they brought him into our clinic. And I'm a developmental theorist, so I try to do family of origin work. And his mother, the clues were his mother went to church every day. And father was sort of, would watch television every night. But there was nothing PTSD-ish. There was nothing complex trauma-ish. There was nothing I could find. So I brought his family, and I brought first his brother in. And I said to the brother, you know, your brother tried to commit suicide. I'm trying to help him. I'm sort of desperate to know more about the family of origin. This is the time to talk about any secrets. Is there any secrets in the family? Anything that you think of that might be important? And he said, oh, no, my mother was holier than thou. She went to church every day. But there was one thing odd. My ears go perking up. One thing odd. What's that? My brother and I were at the shopping mall, and one day we turned a corner, and my mother was kissing another guy. And we couldn't imagine. I said, oh. So I said, okay. So I bring the mother in alone. And I say, anything you could tell me? No, there's nothing you can tell me. Well, the boys tell me that they turned the corner and they saw you kissing another guy. Mother's eyes get really big. She starts downloading. I was incested by my father growing up for 10 years. I never told anybody about this. This is the first time. And she starts crying. Boo-hoo. Okay. Now, what is the mother being incested, since it's a secret? How could that cause the son to be a sex addict? Mission impossible. Do you think they're related? Absolutely. And so as I went into group therapy, I talked to the guy in group therapy, and we're talking about why he did what he did to his wife. He doesn't know, he doesn't know, he doesn't know. You think it might be related to your mother? No, not related to my mom. My mother's holier than thou, loyalty. Well, how about the time when you saw your mom kissing that guy? This guy is a black belt in karate. He gets up and he goes into this karate position, and he starts coming towards me, and it's like happening in slow motion, but I'm scared to death. And the entire group gets up, grabs him and holds him down, and they can barely hold him down. He's so out of control. So finally we get him settled down, get him back in his chair, and I say, well, I think we must have hit something important, because I'm an astute psychotherapist, you know. And holy shit, the rage in this guy was just, well, if your mother goes to church every day and you see her in one way and you see her kissing somebody, it would be very hard to get some clarity about those two scenes and put them in your head. So your amygdala would grab it, put it down and store it in storage, and it would stay in state dependent memory. until later something from, activates it in some way. And so your body, repeats it in disguised form as a way of figuring out what happened, why it happened. Because our brains seem to have these repeater systems that they're trying to make sense of things that make no sense at all. So I find that true in all these cases. It's always about unfinished business.
We got one more question. How does disorganized attachment connect to polyamory or ethical non-monogamy?
You really want to get me in trouble, don't you? Okay. That's a very complex question. And I start as a sex therapist with non-judgmentalism. I do not have my judgment on anybody else about anything. If it works for you, that's great. But this is where my butt comes in. Everybody listen to my butt. Anything that enhances intimacy, I'm in favor of. Anything that blocks intimacy, I am not in favor of. And so if you like people urinating on you to make love with them, I want to treat you. I do not feel like that is reasonable. And so I'm not saying anything goes. I say that if something pulls you closer to other people, including pornography, I'm in favor of it. Anything that pulls you away from your partner is an intimacy disorder, avoidant attachment, I'm against. People use polygamy in that kind of a way. The old data on open relationships was really clear. Most of the people with open relationships ended up divorced. The data on that is indisputable. But that doesn't mean that applies today. Many people with open relationships are able to have very good marriage or committed relationships with another. And if it works, more power to you, great. On the other hand, there are many of them who are dealing with disorganized attachment and intimacy disorder by using open relationships. And when they finally go to the divorce court, they wish they hadn't done it. And that's a subset. So defining which subset is which is really unclear. So, the term I use is egosyntonic or ego-dystonic. If it's egosyntonic, great. And when it becomes ego-dystonic, come in, we'll help you.
And okay, one more here. Using metacognition, how do you determine that the person's defense system is safe for them to relinquish? Evaluating ego strengths, perhaps?
The answer is to go slow. When you're doing trauma work, the golden rule is do no harm. And you teach people grounding, containment first. You do family of origin work. You develop a healthy, safe relationship with the client. You develop a secure attachment with the client. And only then do you begin to take some of this stuff off the shelf, and you do it in a titrated way and do a piece of work and then find out if the client is able to work through that and then get better. And then you take another piece off and so on. And so most of us who do trauma work have learned from our mistakes, and we go very slow. And if we're going to err, we're going to go too slow. I like our model treatment because we treat people usually for 2 months, and we see them 3 times a week. So in 3 times a week, you develop really tight relationship with people. And then they have the other groups to give them the cognitive piece of it and the affective piece. And you do a lot in a short period of time. And as they change, it gives them more energy to change. But every session is you're evaluating ego strength. And if a person gets disorganized, you will see it. They'll begin to have thoughts that are disorganized. They begin to feel like they want to relapse on their addiction, And so in our model, you earn the right to do trauma work by stabilizing. We will not treat you for trauma unless you're stable. And if you're feeling unstable, you better get stable if you want to do your trauma work here. So people have a lot of motivation. Let me give you an example. We treat eating disorders. If you want to work on your trauma, you need to eat the food and you need to stop binging and purging. If you're able to do that, you belong here and we'll do trauma work. That's a lot of motivation because a lot of people want to do that work. If not, go back to another clinic where you can do work on sobriety. And if this is your fourth clinic, go to your fifth one, but get sober, then we can help you. It's a catch-22. You're going to keep relapsing until you do the deep work, but you can't do the deep work until you stabilize. Stabilize, come here and we'll do the deep work, then you won't relapse. And that's the most defensible model. But we will not work with people who we feel like we're going to hurt. Thank you all for attending. I'll see you later.